So first of all, it's a privilege and honor to visit AIMS Rishikesh, and thank you, sir, for giving us the opportunity. I would like to present this data on behalf of ResMed. I work with ResMed. That's a big disclaimer which I would like to give. And probably in the next 10 minutes, probably I'll take you through the new technology which ResMed has acquired, a couple of years back. So this is what the device looks like. It's a very small device. Just you can probably paste it on the thumb on your index finger, and this is a disposable device where we can do multi-night testing, and the device is based on the principle of peripheral arterial tonometry. So right now, this device is also European CE approved, TG approved in 2019, and US FDA approval happened in 2020. So how does this device looks like, and where does it fits in the ASN scheme of things? So as we know, this is the clinical practice guideline for diagnostic testing of adult obstructive sleep apnea. And right now, what we are trying to do is that, if you look at the particular criteria, it says that, if there is a device which uses peripheral arterial tonometry, it also should have oximetry and actigraphy. So right now, this particular device, which is known in India as one sleep test and globally as night owl, conforms to this particular criteria of ASM. Okay, so what is new in this device? So this device actually records SpO2 levels, the pulse rate, peripheral arterial tone, and there is also an actigraphy based on to which there is a sleep-wake discrimination which happens. And of course, there is a AI which runs in the background so that it can differentiate all these parameters. So like I mentioned, this is based on peripheral arterial tonometry. So what typically happens is, if you see these particular cartoons, these are different cartoons which I have taken from the algorithmic manual of night owl or one sleep test. And what it does, it actually shows or tries to detect what's happening in the patient when the patient is sleeping. So suppose if this is an apnea episode, so we see there is a vasoconstriction, there is fall in SpO2 levels, and then there is increase in heart rate. So typically it tries to understand what's happening in the patient based on these three criteria, which is, as you can see, increase in peripheral arterial tone, which is basically the vasoconstriction which is happening, whether there is a pulse rate increase in that patient, and whether there is a desaturation event which is happening. So if these three criteria are fulfilled according to the algorithm, then it says that probably this is a respiratory event which is happening. But there is no way of differentiating whether this is an apnea or a hypopnea. So what are the limitations? What are the strengths of this particular test? So right now the limitation is, all the parameters are derived parameters. These are not direct parameters. There is no EEG-based sleep staging. And also there are few contraindications where we don't use it, like the Raynaud's disease, or maybe in patients who are using, who are typically critical care patients, where the peripheral vascular blood flow is anyways impaired. I mean, those are the patients where there is a contraindication. And of course, for complex patients, we always fall back on the PSG for diagnosis. What are the strengths? It is quite accurate. There is multi-night testing which is possible with this device. What we have also noticed is that there is high level of patient comfort since the patient takes the test from the home. So there has been several studies. We typically quote two different studies, one by Punjabi et al. And one by Argioles et al., which says that if we do multi-night testing, the AHI number which we come to are more accurate, right? So that's why we recommend multi-night testing with this particular device. So briefly, I will go through the two clinical studies which were published. The first of the clinical study was published in JCSM in 2018 by Masi et al. And this was a direct correlation, it was a correlation between night owl sensor and PSG. So what they did was the patient was hooked up onto PSG, and the same patient was also hooked up onto the night owl device, right? And they send this PSG data for an internal scoring within that particular lab. And they also sent this PSG data to an external lab where they used MSS analysis followed by a manual scoring. And the night owl data was calculated by night owl analysis, which is basically the software. And what we wanted to see, how is this analysis correlating with MSSS, which is the external scorer, and also with the internal scorer. So if you can look at the REI of night owl and the MSSS of scoring, we find quite a good amount of correlation. The rho is around 0.8. The p-value is quite significant. And same, the REI of night owl, if we compare with Zol, the rho is around 0.7 with high degree of significance. So I think this is one of the correlation studies, and based on this, the US FDA approval was given. The second study came in the Sleep Journal sometime in 2022 last year. And again, this was more of a correlation because there were a lot of questions from the market that, there are a lot of devices in the market which are similar. And currently, FDA doesn't have any baseline to say that, okay, if this device is correlating with PSG to this extent, this device is appropriate. So what we did was, we did a multicentric study on this. 3 of the centers were based out of US. 1 center was based out of Belgium. And again, similar kind of study design. They took around 167 patients. All these patients were either hooked up to this particular sensor and also with PSG. And then we tried to see the correlation. So as you can see with this scatter plot, the correlation was quite high in, if we use, either the AHI expert, which is the external lab, in comparison to the night owl. So the correlation was quite high. What we also did was something we call as a 4-way categorization. So typically 4-way categorization is done for devices where we implement machine learning. And we found that the 4-way categorization with night owl was close to 70%, which, so because we did a 4-way categorization because FDA doesn't have any baseline, right? Whereas we found the 4-way categorization with PSG to be around 77%. Of course, PSG would be on a higher side, right? So, these are those 2 clinical studies which I'd like to share at this point in time. Currently, we are also in talks with different institutes to replicate similar studies in our country. So just a glimpse of how the diagnostic report looks like. This is the first page. You would get the patient panel, the test info, the pulse rate parameter, and of late, since the last 8 months, it has also tried to give the central sleep apnea flagging. Okay, so that's an AI/ML feature which has come into this device. And this is how you get the AHI data over 3 nights. So this is the ODI panel. This is how it looks like. You would get the mean ODI, T90, the maximum and the average SpO2 levels over 3 nights, the total sleep time and mean sleep time over 3 nights. And these are the graphical representation of the data which you would find also in the report. So I would leave you with these thoughts, and you are free to judge yourself because I'm speaking to all the experts, right? And thank you so much for your kind listening.
So may I request the panelists to take their place on the dais so that we can start the panel discussion. Ma'am. Indu ma'am. So friends, if you have any questions, even online friends, please send your queries regarding this on in the chat box, and we'll take that. So ma'am, just to start, they presented a device which is very small, which can be worn over a finger. Do you think, and there are 2 issues then when we look at the OSA, one is the screening and one is the diagnosis. Can it be used as a diagnostic modality, or should it be limited only to screening?
So I think, the home sleep testing, which we were doing with the level 3 or whatever devices, has been used as a screening procedure, and except in very complex patients like heart failure, COPD, neuromuscular, etc. So, or where you're suspecting central sleep apnea syndrome or something like that. We also know that we would like to ideally live under, the gold standard conditions and do everything as per gold standards. But the truth is that patients do not like to get admitted for sleep studies. They don't like to be connected to multiple wires and belts. It's not a pleasant sensation. So, yes, there's a device which is new, and it's a very small and light device. And I mean, I'm just saying, if I don't tell it to a patient, but I tell it to 10 of my family members, they would also want to use the device rather than get admitted in hospital for a sleep study. So I think the device has a very good role in a potential screening, but it needs to be validated in our circumstances. See, doing a study in the West is not the same as doing a study in India. We have circumstances where there may not be a fan or a AC in a hot environment, and there may be sweaty skin. We also have a lot of co-sleeping bed partners. So we do not, even elderly people or middle-aged people, they're in congested environments where the houses are small. They would be 2 or 3 sometimes. So is there a movement of the device? Is there sweat which affects the recording? And also we need to compare it with, what happens in patients when they are managed. Ultimately, you will have to, after the diagnosis, do a titration study also. So I think it's a very good device for screening. I would not advocate it in complex patients, just like I don't advocate in-house sleep testing in patients who have heart failure or COPD and complex problems. So yes, it's good. It's a choice we have now, and the more choice we have, the more comfortable the patient feels. Previously, 10 years back when we used to do sleep study, we'll say कि घर में ही मतलब hospital में admit होना है. Then the level 3 came, so we said आप घर में भी करा सकते हो, वो भी कर रहे हैं. But now we can say that you can fix it on your own and do it on your own. So that is really a good advancement.
Dr. Tripathi, your take on this, since you also have a technology background and also a medical doctor.
So I'll talk from 2 perspectives. If you just want to handle the burden of OSA, we need technologies which are simple, but at the same time accurate. When I say, because simplicity cannot be at the cost of accuracy. Now, that is number 1. Number 2, when we are choosing a device for the patient, rather than depending upon how simple it is, I will look for what information it is giving to me. Why I'm saying this is, now it is very clear that OSA is a heterogeneous disorder. It is not just like AHI is telling you the whole story about your patient. AHI was a number given in 1970s. It has stuck with us. And we are not, as a clinical community, are not willing to look beyond it. Why I'm saying this is, a lot of research have come out which are pointing to simple things that are available in your PSG report. One of the issues in the report that this device have shown is they're just giving the AHI. They're not telling us, is it obstructive apneas or hypopnea? Because this information is important. Because if patient have got more apneas versus hypopneas, airway collapsibility is more. It is telling me about a phenotype of the person where upper airway muscle compensation is poor. If hypopneas are more, it is telling me something about the patient, that this patient might have high loop gain predisposing to this. Those insights are not available just with AHI being given to me. And I will be uncomfortable just by looking at AHI and treating OSA patients, knowing that it's a heterogeneous disorder. People can question, okay, if you know the phenotypes, what will you do? Your treatment will still be CPAP. My answer will be no today. With all this information, I have more things to offer to my patients. So I feel this device is simple, but the simplicity is coming at a cost with limited information, which I am not comfortable
Most of us are.
in my practice with knowing that so much of data has been output
No,
on the OS.
no, I guess most of the sleep physicians won't be comfortable with that information. Okay, Dr. Lokesh, my next question is to you with this device, and you are a pulmonologist. So, I mean, you are getting a lot of patients with the COPD OSA overlap syndrome. So, do you think this device can be used to screen OSA in those patients?
Sir, being level 4 device, home sleep apnea testing with these devices are indicated for uncomplicated OSA only. Even in that group, this device is basically measure sympathetic surge. So the change in tone during that surge, because so that surge might be because of anything, maybe just because of any nightmare or just because of any disturbance in sleep related to nocturia or something. So what they have done is screened events among obstructive sleep apnea patient, central sleep apnea patients during hypopnea, and all of these disorders. They have measured what are the differences in tone, and then mostly they have applied artificial intelligence over it, so that they can give, and they can differentiate the tone among obstructive event, the tone among other events, so they can give us an idea of respiratory event index. But again, I'm questioning actually the method by which they are doing it, in terms of if sympathetic surge is just because of anything else than respiratory event, we will label it falsely as a event and not just sympathetic surge. So the question was about a patient of OSA with other COPD-like illness, a big no from my side. And even in uncomplicated OSA, I think we have to first validate the device among our population, how much accurate it is, and then we can, have a good faith in it.
Indu ma'am, what do you see? I mean, how do you see the future of this device in the pediatric population?
So first of all, home sleep studies are not validated in children at this point of time. In the lab also, it is not easy to do sleep studies for children. We need to have the assistance of video cameras. The technician has to be a night owl himself. If he's not a night owl, something is pulled and something is broken and something is gone. So I think as a pediatric sleep specialist, it's a far cry for us at this point of time. हम लोग बच्चों में थोड़ा adulterated, it's a step down once it's validated. So I think it needs a lot of validation, though we would be extremely happy if something works like this, because in children it will make it much easier. But doing a home sleep study at this point is not validated.
Yeah, please go ahead.
Now we are clear that there is REM obstructive sleep apnea versus non-REM obstructive sleep apnea, and it has got clinical implications for my engagement with the patient. If
Yes.
somebody have got REM obstructive sleep apnea, I'll be very clear with the patient that you have to use your CPAP or oral appliances for the whole night. You cannot stop it in the middle of the night because REM sleep is going to come later. I don't have that information over here. With all this information already available, if we are sticking to a technology which is giving just a number of AHI, and we are ignoring all the other information that we can get from other technologies, I don't think so we are doing justice to our patients.
Okay, and what is the opinion of the whole of the panel regarding the cost of the device and the usability? Because say this device is being marketed at 2,000 rupees per device. Okay, so somewhere around 2,000 to 3,000, and the device is disposable.
We need studies. We need more data. We need to extrapolate it to the Indian population. And if something like, see, just because it is economical does not rule it in or rule it out. Okay, and I think we need more data. I think you should be forthcoming to have more studies, compare it with PSG. And it probably could come in a screening tool, initially as a screening tool, and then see how it correlates. I mean, see, technology is only advancing. I'm not going to rule out any newer technology. Yes, we are open to new technology, chat, GTP, whatever they call it now. I don't know whether it will bring in and finish humanity, only time will tell us. But the thing is, we're definitely open to new technology, but it has to be validated.
So I completely agree with what Dr. Tripat said, that, we are not going to get so much more information. But remember, we are dealing with a very reluctant population who doesn't actually want to come to the marriage in your sleep lab. So in Delhi, we see a lot of these kind of patients where they're snoring away and they're just agnostic, and you're seeing their neck is thick, you're seeing that their voice is hoarse, and they have, a huge BMI, and they'll say, "Oh, to hum 30 years se snore karte aa rahe hain." So I think it definitely has a place in those people who are in denial. And I have always, maintained that a level 3 or a level 4 device helps you usher in the patient to the lab. Because when you give them a level 3 device and they see the reading, wo lal pe aa rahi hai, then, and lal ka wo matlab likha hota hai wahan pe. So they then press the panic button and come to you. How much ever you tell them ki shayad hai, aap aake test karao, once they've done the home screening and they find it's in the red, they come more willingly. It's also of use in people in Delhi. We see a lot of VIPs, and again, they are always in denial. The ex-chief minister of Punjab and Haryana, Punjab, he also has OSC. His daughter has OSC. And how much ever you tell them ki sleep study karni hai, they will not come to your lab. So I think it's excellent for these people who don't want to come to your lab. You just give it to them, you will get some evidence, you tell them this is a screening, use it as a screening, and if it is positive, then it is indicated to, at least you've done your bit. And it's a bit to prevent a sudden death in sleep or an accident or whatever. So I think it does have a role. Yes, as a scientist, as a researcher, as a sleep specialist, I'm totally dissatisfied with what it does not tell us. It doesn't tell us the sleep stages. I mean, for a neurologist doing sleep, I need the sleep stages. I won't even get sleep efficiency because I won't know when the patient has actually slept. There's no EEG there. But then you have to understand that it's not a device which is going to help you do that. And with what it has, these will be the indicators.
Thank you.
Do we get raw data from this device?
Yeah, please come, please come. No, please come here so that everybody can listen, even the online participants.
So right now, when we look at the dashboard, it's not stretchable. So maybe in 6 months' time, we will have a second dashboard because a lot of upgradations have done. So we are currently working on version 1. In version 2, we will have the raw data also.
Will that be editable? Any information on that?
So that is, a lot of IP issues are there, but we will have better thing. We will have access to raw data.
Okay. So any questions from the floor or the participants online? Sir, please. Yep.
You can look at the raw data and you can interpret it as a sleep technologist, and or the algorithm will anyways give you the data. So you can actually see and check whether the algorithm is working, giving you the right data.
Yeah, that's the future.
That's the
Not
future.
today.
But it will happen. I mean, that is something which we are having in discussion.
Okay, any other question or comment from the floor? Yeah, please go ahead. They have already mentioned in that in present that there are certain contraindications like the vascular diseases, peripheral vascular diseases. Okay, even. Oh, yeah. Okay, so for the online participants, the question is if the person is sleeping in a room which is chilled, having a temperature of 19, maintained through the air condition, will this there is a chance that there will be a peripheral vasoconstriction, and during that time will this device work?
So if you look at those clinical trials, those were done in proper lab setups where ACs were running. Okay, so we haven't seen any bias or abnormality towards having a vasoconstriction when it's this chill.
So maybe I think that's something that we would like to see in future.
I think, sir, you have already shared your proposal. We are working on that, so we'll have more data on very Indianized data on this.
Yeah, sure. Any other comment or query from the house? Okay, if not, so I would like to, ma'am, we can.